The Wellness Hour. An in-depth discussion with today's top physicians and medical leaders. And now, your host, Randy Alvarez.
You're watching The Wellness Hour, leader in medical news and information. I'm Randy Alvarez. Today's topic, advances in the world of pain management. If you are in pain with neck pain, back pain, you have to hear what my first guest has to say. His name is Dr. Pouya Mohajer. Dr. Mohajer, welcome to the program.
Thank you, Randy. How are you doing?
All right. Now, you are the founder and medical director of Southern Nevada Pain Specialists.
Yes.
Now, how long have you been in Nevada?
Actually, I started back in Nevada in 2004.
2004. Now, who's your typical patient? What kind of patients do you see?
Well, I see an array of patients. The typical patient could be a younger lady who's been having severe headaches. Unfortunately, she cannot do her daily activities. She can't go to work, or she's having problems at home. Another type of patient would be your typical golfer who's been playing this passionate game for many years, and unfortunately, because of his back pain, he can't swing anymore, and he's looking for some relief. Another typical patient would be sort of a lady in their middle age, like 50s or 60s, who's been functioning very well, but all of a sudden she develops neck pain or arm pain and cannot stand over the sink anymore to do the dishes or do her daily activities.
A big part of your practice is headaches. Is that right?
Correct.
Treatment of headaches. Tell me about that.
I actually kind of deal with a very specific type of headaches. These headaches are usually the headaches that start in the back of your head or even your neck and are quite debilitating. I don't know if you ever had a headache before or not.
Not like that, no.
No, but unfortunately, these people go through a lot. They've been to multiple physicians and
neurologist,
their primary care physician, their internist, and no one can find an answer. But the neurologists are actually quite good about diagnosing these headaches, but then they don't know where else to send them.
Now, you've written a couple of papers on this.
Correct. Me and a couple of colleagues, we actually published 2 papers on the procedure itself, and we've presented at a couple of pain conferences.
For headache patients.
Correct. These are specifically called occipital headaches or occipital neuralgia.
All right. Now, the patients, and you deal with patients in their 80s. I mean, anybody in pain.
Absolutely.
Back pain, neck pain, and headaches.
Correct. So we don't discriminate on age. I mean, you could be a functioning 80-year-old and you don't want to live the kind of lifestyle you're having. And I've had a couple of patients tell me, like, what happened to the golden years? So,
do you hear those things?
Absolutely. They're like, what sort of a golden years are these if I'm in pain all the time and I can't do any of my daily activities?
So at the top of the show, we talked about advances in pain management. You say it's fairly a new specialty, pain management.
Actually, people have been treating pain for thousands of years, but the specialty in pain is relatively new. Even the board certification, it didn't start till like early 90s.
Okay.
And I'd say over the last 10 years, it's exploded in new technology and new medications that can be used. There are new medications that have for much more pain syndromes that can be treated with less side effects. The use of the technology like the interventional pain procedures that I do, there's been so many more procedures that can be utilized for it and also treated. There's also new technology with spinal cord stimulation. This has been around for
Spinal cord stimulation?
Correct.
Okay.
Correct. This is basically what you're doing is sending electrical stimulation to the spinal cord, which gets transmitted to the brain, and people feel vibration in the area that they have pain. And that's been around for 30, 40 years. However, now there's been many more pain syndromes that can be treated with this, which is quite exciting.
All right, and this is without surgery?
Well, actually, there is surgery involved with that.
Okay.
So it's somewhat invasive, but it's sort of the thing you do when everything else fails, and you go down the line. And this is just the pain aspect of it. There's also new technologies and new procedures in spine surgery. They're doing complete disc replacements now in the neck and the lumbar spine for the appropriate patient.
Okay.
And in field of neurosurgery, they're doing motor cortex stimulation, deep brain stimulation. I mean, the field is just exploding. And whenever you go to one of the pain meetings, and there's new technologies and new uses for almost everything that we've used for the last 20 years.
Do you think there's a lot of people that are in pain, neck pain, back pain in Las Vegas, Nevada? Well, of course, throughout the U.S., but that don't have to be? There's a lot of people suffering that don't have to be?
Absolutely. I think there's tons of people that probably do not need to be suffering in the amount of pain they're in.
Is it because they're stubborn? They're afraid? They're afraid to go to the surgeon? They're afraid? Because, and I told you this on the phone. I said, and you cleared this up right away for me, and that was, I said, you know, going to the surgeon, they're thinking surgery.
Correct.
And you said no.
But that's what the patients are thinking. It's like,
Yeah.
why would I go to a surgeon if I don't want to have surgery? But that's not the way it is, to be honest with you. I have
So before that happens, they're sent to you, usually? I mean, the surgeon?
Yeah, I have a very close relationship with the surgeons. So the surgeons, most of the surgeons I work with, and probably most of the surgeons around, they don't want to operate right away. They want to do whatever is the best for the patient. Let's try a little bit more conservative treatments and see what happens, because surgery doesn't work all the time. And you always have the option to go through surgery if you want to.
Okay.
So at the beginning, it's always good to do the least invasive and proceed from there.
Now, we've talked, and one of the, and I asked you, I said, the biggest problem, if you had to say the biggest problem in the world of pain management is, you said oftentimes the patients are undertreated, undermedicated. Very surprising. Elaborate on that.
I know it does sound surprising, because there are actually a lot of people that are undertreated. Unfortunately, what happens with pain patients is that they only see their primary care physician.
Okay.
And as you know, this day and age of decreased reimbursements and the high rise of healthcare costs, the primary care physicians don't have time to spend that much time.
Is
with
it
their
tough
patients.
to manage the pain patient?
Absolutely.
Because of addiction?
The addiction is definitely one aspect that the primary care physicians do not want to deal with. They're already swamped with so many different types of ailments, and
So they can't properly manage them?
possibly
One of the things? Okay.
Yeah, because once someone comes in and says, hey, I have pain, it's so much easier just to write them a prescription and let them out the door. They don't have time, and it's not their job either to actually treat the patient or find out what the cause is. That's where I come in.
So this is all you do for the most part?
Absolutely. I'm a pain physician, and I do mainly deal with pain patients left and right.
So there is a crowd of people that, chiropractic has failed, physical therapy has failed, and they're so afraid of medication, they don't want medication,
Okay, yes.
that they do nothing, and they live in pain.
And these are the people that we actually want to help. And they're sort of afraid to go to their primary care physician because they think they've tried everything, and then what's going to happen? They're going to be sent to a surgeon and they're going to be cut. And a lot of people have heard horror stories about...
So give us the inside scoop. That's not how it works. I mean, when you're sent to the spine surgeon, their first course of action is?
To hopefully refer them to someone like me.
Okay, a pain specialist.
Pain specialist, because not every spine surgeon wants to operate, because not everyone is a surgical candidate. It's always good to have another set of eyes look at your ailment, let's say, your problem. You want multiple physicians come up with the same answer, then that's the way to go. Okay. So you have the spine surgeon sending the patient over for a particular problem. Then I look at the patient, I examine them, and I come up with my own plan, and then we go forward. I also work very closely with the surgeons. I do send patients to the surgeons as well, not just because they have surgery, but to have another look. Maybe a treatment that I'm doing is not as effective as I want it to be. I want the surgeon to be involved as well, and we kind of collaborate together and move forward.
Tell me this, and tell me if this is true. I've had medical doctors on the show. Our show airs throughout the U.S. and Canada, and they say, Randy, the way it works in medicine is, if you're on a medication and if you're just doing okay, and if you don't complain about it to your doctor, you may stay on that medication forever.
Absolutely.
And so for the pain patients, it's the same way. Should they get, because you say there's new longer acting medications, things like that, how often should they go in and say, go to a pain specialist and say, take a look at my medications. What can I do? Are there any do you ever see people on the wrong medications that go, boy, there's a much better...
Well, I wouldn't say it's the wrong medication, but I think there's probably better medications. There's so many new medications that are coming out with less side effects. Maybe the patient is taking the pain pill that they've been on for a while, but unfortunately they get a lot more sedated and they're falling asleep during the day. The pain is well taken care of, but they're not functioning. My whole goal is try to get the patient back to functioning. Okay. This day and age, me as a pain specialist too, the 0 to 10 scale has been overused, I believe.
0 to 10 pain scale. Tell me about that. What do you mean by that?
It's called the visual analog scale, like 0 meaning no pain, 10 meaning the worst pain imaginable in life, like you want to jump out the window.
But you say it's overused, the pain scale. How so?
In the sense that it's a great scale to compare people in pain of certain syndromes. But in my opinion, I think in addition to the VAS pain scale, you should use functionality. I'd rather person to
so getting back to what they normally do.
Absolutely. I mean, that's more important to me if someone comes in and tells me, hey, I was able to vacuum the house last night, or I was able to do the dishes. I was able to stand over the sink and to actually do the dishes, or I was able to have relations with my significant other. I mean, that's much more important to me than someone goes from a VAS of 8 to 6 out of 10, which can also get you to function the same way, but knowing what the patient does, it's much more important to me.
So let's move into what you do most of, which is injection therapy. First course of action sometimes?
Absolutely, absolutely.
Okay.
So again,
let's go low back pain. Low back.
Okay. Again, it's more of a systematic approach to everything. So I evaluate the patient, do the physical examination, look at their diagnostic images, and come up with a plan. And most often the plan involves an injection. So,
and by the way, what is the cause of most of this back pain? Most of the back pain you see.
So the back pain, if you want me to show you in a model,
Sure.
I think it'll be a lot easier. I brought a model so we can discuss it. Most of the issues with back pain is a change in the musculoskeleture of the lumbar spine, of the lower back, basically. So this is a typical model that I brought. So there's multiple structures in your back that could actually be the culprits for the pain. So this is why I was talking about trying to find out where the quote-unquote pain generators are. I'm trying to figure out where the pain is coming from. So you have the soft tissue just underneath your skin, which would be back here. Then you have your muscle, you have your joints, and these are called the facet joints. These joints actually allow your spine to go forward, backwards, and side to side. People develop arthritis in these all the time. Then you have your nerve roots, which come around the side of your back. Then you have the discs between the vertebrae, which cushion your vertebrae. And then you have the bony structure of the vertebrae themselves. So all those structures can cause pain.
But most of this is because something, and I just want to know if I understand this correctly. A lot of it is because something is hitting the nerve, or rubbing or irritating the nerve?
That's one possibility. Usually when something is rubbing and irritating a nerve, you get sort of what people call sciatica. You get this pain down the leg, the sharp shooting, the burning sensation.
Oh, that's nerve pain.
That's nerve pain. Like you can't get out of the car, you bend over, you picked up something, you heard a pop, and then you have a zing down the leg. And then that's the irritation of the nerve.
Okay.
So we do injections for those. And then you also have just pure back pain that could be coming from the disc itself or any of those structures.
So how does an injection help though?
So the injection is actually
what are you injecting in there?
So it's a combination of two medications. It's a local anesthetic, which actually numbs up the area. So that usually gives you immediate relief. Okay. And then we have a combination of a steroid injection. The steroid is basically an anti-inflammatory. Decreases the inflammation around the area. And what that does is allows us, it gives me a couple of pieces of information. First of all, if you get relief, then I know we're in the right area. And the duration of the relief is important as well.
And some people can get relief for how long? 6 months?
It depends how long you've actually had the problem. The longer you've had something, sometimes the more difficult it is to treat it. It can vary. It can vary for anywhere from days to weeks to months. I've had patients get one injection, they're good for several months.
So where are you shooting into? I mean, where are you hitting it?
So
how
basically,
are you doing it?
For example, like say you have this sciatica. This is this quote-unquote pain down the leg. So it's usually, for example, this represents a bulging disc that's irritating the nerve.
Okay.
So what I do is under X-ray guidance, we have a very state-of-the-art X-ray machine.
You're doing an injection, looking at
an X-ray image on the screen.
Like live. It's live.
Live. It's exactly. It's live because you want to know where you're going.
Okay.
You know, you don't never want to stick a needle in someone's back when you don't know where you're going. So put a needle in the right spot, and then I inject what's called a contrast, and it outlines the nerve. Then I know I'm in the right area. Then I inject it to the combination of the local anesthetic and steroid. I do give sedation to patients during this process.
So there's no pain?
There's no pain per se. Most of the patients are very comfortable. They might feel a little bit of a bee sting on their skin when I numb up the skin, but 99.9% of the time they don't even remember that. Some patients are actually conversing.
How soon can they feel better?
So with the local anesthetic, they should actually get some immediate relief. With the steroids, it takes about 2 days to kick in. They peak at about 5 days, and then they stay elevated for about another 20 days or so. And what I like to do is actually see the patient a week after the procedure to see how they're doing. Again, this is part of the whole system of fact-finding mission. If they're improving, great. We continue with this. If
a lot of technique in this, by the way. I mean, are there those patients that say, I've tried injections, they didn't work, you get them, and then...
Well, you never want to say someone's better than anher person, but...
Okay, but it hasn't happened?
But it has happened. And then again, also they might have done a procedure that it was for a different type of pain. Maybe the patient has a different pain now that they come and see me, and they actually responded so much better than they did before.
Now, for pain patients, is this something every single pain patient tries at least once in their life, an injection? Do you still have patients that come in and say, I've never done an injection because of...
They're scared.
Really?
Yeah, they read some stuff on the internet. Maybe they've heard from their
Paralysis,
patients.
right? I mean,
Yeah. Well, anything is possible in this world. You could walk across the street, get hit by a car, but the reported complications for the injections are very minimal. And I've been in practice 5 years. It's never happened to me. But anything, again, is possible, but it's very minimal.
So it's very safe.
It's very safe.
Insurance covers it.
Insurance covers it. I have a full staff that's actually present during this. I'm a board-certified anesthesiologist. I also have another anesthesiologist there that actually administers the IV.
Oh, really?
Yes. So, because I want to concentrate on the patient, and then my anesthesiologist concentrates on making them comfortable and happy.
Sleep really is affected for the pain patient.
Correct.
Is that correct?
Correct.
They sleep better? They tell you that? They sleep a lot better?
Oh, afterwards, of course. Again, most of these patients, unfortunately, they take multiple medications for sleep, and unfortunately, that's sort of masking what the problem is. If your problem you're not falling asleep is because of pain, just taking a sleeping pill is not going to make you go to sleep.
All right. So
or if it does, the first few
inflammation,
days.
the problem.
Correct.
Now, are there people that their goal is to get off medications, that injections can work for them to help wean off medications?
That's my goal.
Okay,
That's what I tell them. They come in, I'm like, listen, you don't want to be on medications for the rest of your life. And it's not even going to work anymore after 5 years. You're already on such high-dose narcotics. The goal is to try to get some function back. I have so many patients that I've got them off the narcotics, and they always think that they're functioning very well, and their thinking is great. But once they're off the medication, they realize, oh my God, I was in a haze all this time.
Really?
And the goal is to cut down as much as we can.
So the difference with this, there is no haze. There's no medication side effect.
Not with the injection.
With injections,
but
okay.
Unfortunately, with some of the narcotics that they're on, there are.
Okay.
So those are the ones that we want to try to cut down. Even if you're able to cut down, you take 1 or 2 less pills a day. That's just that's so much better for your body.
Okay, different types of blocks. I'm taking it from your website. Selective nerve root blocks.
Correct. So this was exactly what we just discussed. Okay. So this is the people that have the pain that goes either down the leg or down the arm. It's just a bulging disc that's impinging on the nerve and is irritating it. And what we're trying to do is decrease that inflammation around that nerve.
Okay, now this you're part of a trial. The spinal cord simulator trial?
It's a trial that I do, correct. So this is mostly for patients that have had either multiple surgeries in the past, they've not done well. There's people that have done almost every type of injection and nothing's worked for them. And they're kind of at the end of the road. They're on high-dose narcotics, and for the appropriate patient.
So what is it, by the way? What is it?
So it's a
they've
it's
tried
a device.
Everything. They're in pain. Their medications have to be up. Right? Am I painting a realistic scenario, by the way?
No, it's true. It's true. And then unfortunately, a lot of the surgeons don't want to deal with these patients anymore because they just need more medication. And this is where sort of the undertreatment comes in. Not so much they're undertreated because of medication, they're undertreated because of the procedures. So there's another options for these patients.
So this new trial that you're about, so it is FDA approved or it's in the process?
No, it's FDA approved. This has been around for several years, but now they're using it for multiple more pain syndromes that people were not using in the past.
Okay, and so what does it do? Success. How is it different than everything else?
So what this does actually, there's a trial involved. So you actually have this in for several days to see if you like it. It's sort of like test driving a car.
Okay.
So if you could, now unfortunately you can't test drive your surgery, but you can test drive a car. You can test drive this. You have it in for about a week.
You have what in?
It's a piece of metal, plastic tubing that there's 2 leads on it that's placed into your epidural space, which is an area just outside your spinal cord. And this, what it does is transmits some vibration, transmits current that goes through your spinal cord, gets transmitted to the brain, and you feel vibration in the area that you have pain. And people prefer the vibration to the pain.
We're going to take a quick break. We come back, more about headaches. I mean, you're doing something not everybody even knows about, you say, medical doctors, for headaches.
Correct.
Okay, in fact, this is one of your favorite topics?
Yes.
Okay. You're watching the Wellness Hour, leader in medical news and information. I'm Randy Alvarez. We're talking about what's new in pain management. With us, we have board-certified pain management specialist, Dr. Mohajer. We'll be right back. You're watching the Wellness Hour, leader in medical news and information. I'm Randy Alvarez. Today's topic, the latest advancements in the treatment of pain. New hope for people with low back pain, neck pain, and headaches. With us, we have probably the top doc in Las Vegas. He is the medical director and founder of Southern Nevada Pain Specialist, Dr. Mohajer. Did I say your name right?
Mohajer.
Mohajer. Okay,
yeah, sometimes it's a hard name.
It is a hard name. Okay. So now, as a recap, though, because, we talk at the break, you say there's a lot of people, Randy, I want to get this across, a lot of people that are in pain that don't have to be.
Yes.
Say it in your words. I mean, elaborate on that.
So basically, you have people that have had pain for a very long time. They've gone to multiple physicians, they've done multiple injections, or they've tried everything under the sun. But because of the way pain medicine is over the last several years, it's I mean, there's so many new opportunities, there's so many new drugs, there's so many new injections. So I think it would be very well worth it for them to speak to their primary care physician, to their internist, to their surgeon, and look on the internet and try to figure out what's going on.
So I'm clear. So because I've said it a couple times in the show, they don't need a referral to see a specialist like you. They can call you directly.
Absolutely. They can call my office, and then if they need a referral or something, my office will inform them of what needs to be done. But all they have to do is call my office, or they can call their primary care physician and then be referred.
Okay, good. And your website, because I've looked at it, very informative. They could go there, talk about all the different injections, things like that. So what do you want patients to do? They come in, they bring their medications, their images, their MRIs, etc.
Yeah. So they'll call my office. They'll give them sort of like the rundown of what they want. They come in. I have a pretty comprehensive intake exam report. Okay. So they come in, they bring their images. I do my evaluation, my interview with the patient. Then I do a comprehensive examination. Then we both, me and the patient, we look at the images, and then I formulate a plan. Okay. And then we'll go from there.
So this new, technique, this new injection therapy you're using for headaches, you wrote a couple of papers on it. You say a lot of medical doctors don't even know that it exists.
They know the syndrome exists, but they don't know how to treat it, or they don't.
So this is good news, and a lot of medical doctors
absolutely.
will watch the show. Mm-hmm. So let's talk about it.
So I specifically deal with a special type of a headache, which is called occipital neuralgia or occipital headaches. So these are basically the headaches that start in the back of the neck or back of the head, and then they radiate or come across the top, and they could be excruciating. Unfortunately, the main type
more
of people,
men get it than women?
More women actually get it, unfortunately, and it's quite debilitating. They end up not being able to do anything. Their job suffers, their home life suffers. And
how do they hear about you then? I mean, how do they hear? Who sends you this type of patient?
I get a lot of these patients from neurologists because they do several injections, and then they either they diagnose it or they send it to me and I diagnose it, and then we go forward. So we do actually a very interesting aspect with this, because I smile a lot. I'm laughing about it because actually we have had great results, and we've done this in over 300-400 patients. And basically what we do, we try to, again, it all goes back to the systematic approach about how I do things is, first of all, we have to diagnose it. So what I do is I examine the patient, make sure that
Are you touching them?
Absolutely. So the patient comes in and I examine their neck and their head. If they're actually getting this particular type of headache from my examination, I know that they'll probably do very well with this. So what I do basically initially is what's called a diagnostic injection. So I do with just a local injection back of their head with a local anesthetic and a steroid.
Yell at this point?
No, they don't yell. No, they don't yell.
Okay,
they're comfortable,
okay
so they're okay. But there's no anesthesia at this point. But so I do the injection. And I try to do it when they actually have the headache, because then within 5 to 10 minutes, I usually try to do one side to compare both sides. Within 5 to 10 minutes, that side should be completely headache-free. And the people that actually do have this ailment, they will be headache-free in that area.
That same day?
So what within 5 to 10 minutes.
And what are you injecting?
It's a local anesthetic and a steroid. The local anesthetic is the part that gives them the immediate relief, because it numbs up the area.
People that have had headaches for 10, 15, 20 years?
Correct. If it's due to the occipital neuralgia, they actually get excellent results right away. And this would tell me, again, this is the part of the diagnostic part, so I know what's going on. So we do this, and then they go. I give them a pain log. They have a sheet that they rate their pain, again, back to the famous VAS score from 0 to 10. They rate their pain, then they follow up with me. If they're pain-free.
What do they say to you, by the way? Okay, so you do it, you say 10 minutes, and what do they say?
Incredible. They can't believe it. And they want me to do the other side. Sometimes I do, sometimes I don't.
What do you mean the other side? So
so the nerves come on both sides. So I try to compare one side to the other, and I like it to have what's called a control side. So if they have headaches on both sides, I do the side that's the worst, and then we'll go from there.
And this is running up the back of the neck?
Correct. It's formed in the neck, and then the branches come across in the back of the head.
And is this another one of those things people are really afraid of?
No, I wouldn't say they're afraid of it. They just don't know about it.
Really?
Yeah, they don't know what the treatment is and stuff. If you've dealt with anyone with headaches, they'll do anything to get rid of their headache.
Okay.
So, in fact,
would you say there's two thousands of people in Nevada that are candidates for this?
Yeah, there's not very much research on the incidence of this or prevalence of the headaches, but unfortunately sometimes it falls under migraines, which is not a true migraine. So there's a lot of people that are underdiagnosed. Maybe they're diagnosed with migraines because they have some headaches in the front of their head as well as their back. The back and the front of the headache could be completely different. So you can actually treat one, and sometimes the front one gets better, sometimes it doesn't. So it's always good to get evaluated. Talk to your internist, primary care physician, or neurologist. And the neurologists are excellent at diagnosing these as well as pain physicians.
We're out of time. Okay, final message though. Somebody, neck pain, back pain, they think they've tried everything, especially the headache patient. What do you say?
Call your primary care physician, call your surgeon, or call my office, and we'll take care of it.
And get started right now.
Absolutely.
And insurance covers this. So,
insurance covers it.
All right.
And we just want to, again, the main goal is functionality. I want the patients to be able to function.
Get their life back.
Exactly.
Golfing and walking around and things like that at the gym.
At the gym.
Do you have those stories? I mean, you have those stories where it's like a miracle all of a sudden. I mean, do you have those people?
Oh, absolutely. There's a handful of patients that have done extremely well. There's a lot of patients that have gone back to the things they've never done before. And again, the goal is not pain-free. The goal is to make yourself be able to do what things you used to do.
All right.
Get back to your life.
All right. I want to thank you so much for coming
Thank
on the
you
show.
so
Very
much.
interesting.
Thank you.
Good job. You've been watching The Wellness Hour, leader in medical news and information. I'm Randy Alvarez. If you would like to see this interview again online, visit our website at wellnesshour.com. For now, I wish you good health.
Thanks for watching The Wellness Hour, the leader in medical news with your host, Randy Alvarez, the authority on health issues.